Dr. Jenn Simmons, we've had you on the podcast before. You're a dear friend, an amazing colleague, and your knowledge in the area of all things cancer, specifically breast cancer surrounding women's health it's just amazing. I mean, it blows me away every time we talk. And I really, just like we were talking off air, I don't think that there's a limit to which we can drive home the point that hormones, bioidentical hormone replacement therapy is safe, safe, safe. Whether you have a history of breast cancer, you're an active breast cancer, you're post breast cancer, your mom had breast cancer, your sister and aunt had breast cancer, you're Angelina Jolie and you have the BRCA gene. Don't be cutting off your breast. Just let's dive into all things hormones, breast cancer, and women's health with Dr. Jenn today. So thank you for coming on. I love this
you for
discussion.
being here. Thank you. Thank you for having me. We had a great discussion last time. I'm certain that this one is going to be even better and chock full of really important information that everyone needs. So I'm happy to dive in wherever you want to start.
Well, so let's just start for anybody maybe clicking on this for the first time that has never heard us or me with another guest talk about the importance of bioidentical hormones and the safety. So let's just start with BHRT. Who do you feel, the general statement, who is a candidate for BHRT? And then as we get into this discussion, we'll talk about who might not be a candidate for that.
Yeah. I mean, I think the much shorter discussion is who is not a candidate, right?
Okay.
Because I really think of every single woman as a candidate, right? As we start to go through life, when we look at hormone levels, and first we have to completely dispel that total misunderstanding that was entirely created by the pharmaceutical industry that estrogen causes breast cancer. It is just it's an absurd concept. It is ridiculous. If you believe that estrogen, that biological endogenous estrogen, the stuff that is produced by our ovaries, causes breast cancer, then you at the same time have to believe that we were put on earth for the purposes of getting breast cancer, right? It's a ridiculous concept.
Right. And when we say it like that,
yeah. And when we look at the times that estrogen is really in abundance, right? We look at the late teen years, the 20s, the 30s, during pregnancy, when estrogen is 10 times higher than the rest of the time. These are not the times that we're seeing breast cancer. We're seeing breast cancer in women whose estrogen levels are declining, in women whose estrogen levels are barely measurable. These are the times when we're seeing breast cancer. Now, I am not saying that breast cancer doesn't happen in young women. It does.
Right.
We have a whole host of environmental issues that we are dealing with now that we were never dealing with in the past. So we are not living on our grandmother's earth. We're not even living on our mother's earth. So we have a level of toxicity that simply is unprecedented, that we did not have to deal with before. And that is without question contributing to breast cancer diagnoses and a lot of diagnoses, right? I mean, we can walk right into your wheelhouse and talk about metabolic health. Right? We are dealing with a crisis in metabolic health that is unprecedented, that we have never, ever, ever seen before.
Right.
And I think the last number that I heard quoted was that more than 90% of people have metabolic dysfunction in the United States. More than 90%.
Yep.
This is crazy. And without question, that is directly related to both the incidence of breast cancer and the progression of breast cancer. So people are getting breast cancer because of metabolic dysfunction, and they are getting more advanced, worsening breast cancer because of metabolic dysfunction. They're having recurrences because of metabolic dysfunction. So, this is a huge issue. But what's not the huge issue, and what hasn't changed in centuries, is estrogen, right? Like,
Yep.
we are modern beings living on a very old gene code. We don't suddenly have more estrogen. We don't suddenly have bad estrogen. Estrogen is not the problem. And I cannot say that enough times, right? Estrogen is not the problem. And even when we look at the one study that called out hormone replacement as the problem, right? The Women's Health Initiative. When we look at that one study, which was poorly done, and the stop the presses, hormone replacement causes breast cancer release that hit the newspapers and stuck in everyone's head, people, patients, practitioners alike, like everyone got stuck in that loop. Even when we look at that, when you look at the estrogen alone arm, and that wasn't even bioidentical, that was synthetic estrogen.
Right.
When you look at the estrogen alone arm, those people did better. They had 25% less breast cancers than the control arm. And yet, where was the stop the presses for that? Right? Like, we just, unfortunately, the pharmaceutical industry very much wants people to believe that estrogen is a problem for the purposes of selling estrogen blocking or estrogen lowering medications.
Or birth control.
Yeah.
Or
birth
synthetic.
control.
Right.
Yeah. Or synthetics, right? And synthetics are a problem. And we definitely need to talk about that, because there is a world of difference between these synthetic, well, I'm going to struggle with the word synthetic a little bit, because even when we are talking about a bioidentical, we are still synthesizing them from a precursor to estradiol and a precursor to estriol in plants that we then synthesize into the bioidentical. So the distinction that I want to make is not so much synthetic versus non-synthetic, because that's not really what's happening, but bioidentical versus non-bioidentical. Because bioidentical, though it is synthetic, when we use it, and we can talk about how to use it because that matters too. But when we use bioidentical hormones, they act like they should act in our body. And they are protective, they are biologic, they are physiologic, they're doing what they're meant to do in our bodies. That is very different than the non-biologic hormones.
100%.
And when we take non-biologic hormones, like a birth control pill, we see some very serious ramifications of doing that. And the effects of that run the gamut from mood disorders, from weight gain, from infertility, to
thyroid
breast
dysfunction.
Cancer.
Yeah, breast cancer, thyroid dysfunction. Yep, absolutely.
And so synthetic, non-bioidentical hormones are a problem. There's no doubt about that. We have plenty of data that we know supports that. Here's what we don't have data for. We don't have data for the dysfunction caused by bioidentical hormones. We only have data that shows that these are safe and effective. And so for me, unless you have known cardiovascular disease that, would absolutely 100% preclude you from going on hormone replacement, and I don't even know that exists. Right. Like, for me, I really don't have anyone that I'm saying no to. I might be saying not now, Because if I have a woman who is just coming to me with a breast cancer diagnosis, who is highly, highly, highly inflamed, who we have tons of stuff to work on in terms of getting her diet straightened out, getting her on a movement routine, getting her to prioritize sleep, getting her to, get away from so many EMFs, getting her to clean up the mouth, because the mouth is a huge source of inflammation. So when we have a lot of stuff to work on, I'm not going to pile on hormone replacement onto that person, because what they need in that inflamed state and what they're going to eventually need are two very different things. And I don't want to confuse the picture.
Right.
Right. I want to do my investigations, but I want to make sure that I am firmly installing those pillars of health first before I start manipulating their hormones. But there's really not anyone that I am ultimately saying no to, unless it's someone who's just like, I'm not interested in doing the work. I just want you to give me hormones. For me, I'm just not comfortable with that. I know that there are people that will do that. It's just not for me.
It's not going to work. It's not going to, you're going to end up with a dissatisfied patient who thinks that hormones are a magic pill, and they are magical, and they do give life and they give a ton of benefits, but it has to coincide with lifestyle changes and full body support, or it's not going to work.
100%. I mean, the reason that we all went into functional medicine is because we want people to have optimal function, but that is a partnership. That is a partnership. It's not me giving you a pill, because that's just conventional medicine in a different form, right? And that's not what we're about. We're about helping you to achieve optimal function, but we can't do that alone in a vacuum, right? Because we know that health happens at home. And you can have a brilliant meeting with your patient, and if nothing changes after that meeting, nothing's going to change.
Yeah. Nothing's going to change. Absolutely.
Yeah. And so it really has to be cooperative. It has to be a partnership, and it has to be, two very willing participants.
So what do you say to the woman that comes in, and let's say she has had HR positive breast cancer? Can you go over what that means, first of all? And then what would you say to her regarding hormone replacement therapy? Because I've had these patients that are HR positive, and they're scared. They're scared to use hormones because of exactly what you said, the Women's Health Initiative study. And now their oncologist or their family doctor or their friend told them, oh my God, no, you don't want to use hormones. That's going to feed your cancer.
Of course. I mean, we have this whole fear culture that is completely built around this kind of paternalistic medicine, where like doctor knows best, right? And we just have this like hammer nail syndrome, right? Like estrogen receptor, estrogen block, estrogen receptor, estrogen block.
Yeah.
So first, it is absolutely normal to have an estrogen receptor on a breast cell, right? Like, how do you think the breast cells get their normal signaling? Because they have an estrogen receptor that binds the estrogen, which then sends these signals into the cell of what to do. And I'm using estrogen as a general term, but there are actually three forms of estrogen. There's estradiol, there's estrone, and there's estriol. And so they each have a different primary function. But for the purposes of this discussion, let's just use them kind of together as one. So it is absolutely normal to have estrogen receptors on the breast cell, and no one's talking about that, right? Like they're making it like it is some unique property to a breast cancer, and that, if you have a breast cancer with estrogen receptors, oh my God, you can't have any estrogen. Well, look at what happens to these women who go on these hormone blocking drugs. I'm not even going to talk about tamoxifen, which basically tamoxifen blocks it occupies the estrogen receptor and stimulates it differently because it's just a synthetic estrogen. Like, it's so crazy to me that they tell people that you can't have estrogen, and then they prescribe tamoxifen, which is a synthetic estrogen. And no, 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 don't talk about that. Like, hide behind the name. But
Wow.
these women that are postmenopausal and go on these aromatase inhibitors, this is a drug that really only works on non-ovarian hormone production, which is why it's only given in the postmenopausal woman whose ovaries are no longer producing estrogen and progesterone. So the women that go on these drugs, and at that point, because they're postmenopausal, you and I know, because we measure people's hormone levels all the time, a postmenopausal woman, how much estrogen does she really have in circulation? It's like almost immeasurable, right? It's
Right.
nothing.
Zero. Yeah.
And when you take away that almost nothing, what happens to these women? They immediately become horribly symptomatic, and they're talking about fatigue. They're talking about joint pain. They're talking about muscle weakness. They're talking about brain fog. They're talking about sleep disturbance. They lose any libido they had. They have vaginal atrophy. They bleed. They can't even have sex.
No.
Right? Because
Too
it's
painful.
so painful.
Right.
And there's not enough lube in the world to make sex enjoyable when you have horrible vaginal atrophy.
Right.
And they become incontinent, right? They have to wear diapers because anytime that they laugh or sneeze, they have urine come out.
Yep.
And not to mention that their cardiovascular disease is so accelerated that they are dying 2 to 3 times more frequently than the woman without breast cancer of cardiovascular disease.
Right.
Right. So we're basically taking these women and taking away years of their life, quality of their life, right? And people on those drugs are also having a recurrence, just like people not on those drugs are having a recurrence. And they're quoted these crazy numbers, which are relative statistics and not absolute statistics. So like and I also worry about any and all of these studies that say that these drugs are effective at lowering breast cancer recurrence, because who pays for all of these studies. They're paid for by the very company that's making these drugs.
Right.
So, but even the absolute numbers that are published in these studies, they're minuscule. It's like 1% advantage. What are you doing all of that for a 1% advantage and to feel so awful? And what ends up happening is most of these women don't even feel comfortable confronting their doctor about it, or they've confronted their doctor and their doctor just said, well, this is the price that you have to pay. So they just stop taking the drugs and don't tell their doctor about it. So now the doctor thinks that like they're on these drugs and that's the reason that they're doing okay. And like, oh, well, I have plenty of patients that don't have joint pain and don't have this and don't have that are taking that drug. Really, you don't, because you think that they're taking the drug and they're just not. And because these drugs are awful. They're awful. We are not meant to be without estrogen. We have estrogen receptors everywhere for a reason, right? Because our brains can't work without it, because our heart can't work without it, because our blood vessels can't work without it, because our bones can't work without it, our joints can't work without it, our gut can't work without it. We can't sleep without it. We can't have healthy skin without it. We can't have a healthy genitourinary tract without it. Can't have a healthy mood without it. Right? Like, it is literally the hormone of life.
A life.
We can't take it away. And we know that we shouldn't take it away. I mean, that's the one thing that we have to have learned from the Women's Health Initiative, that even with that non-biologic estrogen, we saw a 25% reduction in breast cancer. And we know when we look at the population of women that take hormone replacement and the ones that don't, everyone's going to get breast cancer. I don't mean everyone is going to get breast cancer, but I mean people who take hormone replacement are going to get breast cancer, just like people who don't take hormone replacement are going to get breast cancer, because we're living in the kind of society that just fosters disease, right? But when we look at the women who are taking hormone replacement and compare them to the women that aren't, that get breast cancer, the outcomes in the hormone replacement group are much better.
Right.
Much better. They
Right.
live longer, they live happier, and they live healthier. And conversely, when we take women who have had breast cancer, regardless of whether or not it was hormone positive, if they take hormone replacement after they have breast cancer, they have greater longevity and greater quality of life.
Well, that's what I was just going to ask, is because we know that hormones definitely give life and expand the
Yeah.
quality of life, improve upon the
Yeah.
quality of life, hands
Yeah.
down. But
Yeah.
then when you start really diving into the properties of hormones, even outside of estrogen, okay, we wouldn't give estrogen without progesterone, and progesterone is anti-proliferative. So adding in the progesterone with the estrogen now sets you up for a greater degree of protection against occurrence or recurrence. And then
Yeah.
you start looking at testosterone as well, which is very, very fascinating as it relates to cancer. Oftentimes it's added in. I heard a story from another guest I interviewed that she had, this is a male now, she had a male with either testicular or prostate cancer that came in. It was pretty far along, not looking really good. His quality of life obviously was zero, and his testosterone was low. And she gave him testosterone replacement therapy to get his
And
levels back up.
doctor was probably horrified.
Right. Absolutely. But it was at that point of like, well, I mean, what do we have to lose? Like, this guy's probably
Yeah.
going to die anyways. He's end stage. So let's just improve his quality of life. Well, his cancer shrunk and he
It
ended up
reversed his disease.
living way beyond, like, he was given 6 months. He's now like 6 years down the road, cancer free.
Yeah.
Now, I'm not saying testosterone is going to cure your cancer, but that's a very powerful story of how protective all the hormones are. And you got to wonder, why are we so scared of them? And we could go down that rabbit hole. Yes, there's the Women's Health Initiative study, obviously, that started the scare. But since then, we've had the authors of the study come out and basically tail between their legs say, yeah, we were wrong.
There was a whole retraction paper printed in 2017. The problem is no one read it.
2017. Right? And we are in 2024 right now.
Yeah.
And 2 weeks ago, a patient of mine was berated by her PCP for taking hormones, like literally berated. And my husband asked me last night, I was telling that story, and he asked me why. And I told him the whole Women's Health Initiative study, the largest, worst done study to date, and probably one of the worst things that could have happened to humankind across the board, especially women's health. I mean, it's just a shame. So how do we break out of this? Besides, us screaming it from the rooftops, you writing a book, I mean, us having our own podcasts saying to women, hormones are healthy, they will protect you. What else can we do, Jenn? What else can we do?
Well, I do want to get back to the testosterone, because it really ties into it. Once you understand what these various hormones do, it starts to make sense of why you need them and why pulling them away only worsens disease states. So we talked about metabolic health, and we talked about the importance of maintaining metabolic health, because when you start to lose metabolic health, what that looks like in your body is you lose your insulin sensitivity. So as a result, because it's so important to control blood glucose levels, because the amount of glucose in your blood, when it gets too high, it causes very significant problems in your body. So your body really works hard to make sure that that doesn't happen. And the way that it does that is it will release more insulin and tell your body to get that glucose out of your blood and store it. So what happens is at a certain point, when the cells are full of glucose and really can't take anymore, they start not listening to those insulin signals, right?
Right.
And that's when insulin resistance kicks in. Well, if you still have a lot of blood sugar, and even though you already have what should be adequate levels of insulin in, you just send out more, send out more, send out more, right? And that's when insulin resistance is kicking in. Well, every time you raise that insulin, you're also raising insulin-like growth hormone. This is basically rocket fuel for cancer growth. It's rocket fuel for cancer occurrence and recurrence, right? Well, the key to metabolic health is maintaining your muscle mass.
Yes. Yes. Preach it. I love it.
Right? And so, as a teenager, as a 20-year-old, as a 30-year-old, it's pretty easy to maintain your muscle mass because you have adequate levels of testosterone and you don't have to do that much to maintain your muscle mass. And then, when we look at the kind of generalized tables of what hormone levels are according to decade, you can see that you peak in your 20s, and then in your 30s, it's not significantly less, but it's less. But then it really starts to plummet in your 40s. And it gets so much harder to maintain that muscle mass when your testosterone levels drop off, because that's kind of under the purvey of testosterone, is maintaining that muscle mass. And when you lose that muscle mass, when your muscle gets replaced with fat, this is a huge problem in the metabolic world. This is a huge problem in terms of metabolic health. And that's what's happening. And it's happening for two reasons. First of all, we haven't figured out as a society that you need to move away from that like heavy duty cardiovascular exercise to you need to do strength training. You have to, it's unavoidable. You have to lift some heavy shit. I'm sorry.
I love
I
it.
hate it too.
I didn't
Right?
even pay her to say this, by the way. She's saying this on her own. You're speaking my language, girl.
I'm just out there letting everyone know that I do it 2 to 3 times a week. I do it screaming and crying. I freaking hate it. My very dear friend, Jenn Moore, is my trainer. I call her all kinds of names the whole time we're doing it. I hate it, couldn't hate it more. Every time I'm headed over to the gym for my workout, my husband's like, have a great workout. And I'm like, it's so mean. You know how much I hate this.
Well, at least you're honest about it. That's the key. And you still do it. So there you go.
But the bottom line is we have to do it. We have to do it because there's no other way of maintaining your muscle mass unless you're calling on your muscles, right? Like you have to use it or you will lose it, right? So that's one part of it. Another part of it is we get very, very bad at absorbing protein as we get older. There are a number of reasons why. Some of it is we just make less stomach acid as we get older, and stomach acid is so important in terms of breaking down protein because we have to break it down to those amino acids. We have to break it down to that smallest common denominator in order to absorb them. And with our decline in digestive function and with the fact that like people wolf down their food and eat on the run and eat in a way that is just not good for digestion and eat too fast and don't chew, and it's all a process that we're just not respecting enough. Like we've gone from sitting around the dinner table. We have, and that's a problem. That's a problem. So that's part of it. And the other part of it is that like we're not enough about our food and what we're eating and the quality of the food that we're eating. And so that definitely contributes. And then there is the part that is like the 800-pound gorilla in the room that no one is talking about, and that's testosterone.
Yeah. My favorite hormone. It's the get shit done hormone, because that's what gives us that drive, motivation to go and work out. Even if you don't like it, you're still going because you're taking testosterone for your quality of life, for your libido, for your motivation, for your brain, for your heart, for your bones, for cancer protection as well.
Yeah, absolutely. And we're not talking about it enough. And I would be remiss if I didn't talk about the fact that, you know, when you lose your libido, like so many people are like, oh, it's no big deal. It's a really big deal. It's a really big deal.
Okay, why? Tell the audience why, because I agree with you 100%.
So, you know, for those of us who have been in very long-term relationships, it is one of the most important parts of connection is that physical relationship that you have with your significant other. And if you lose your desire to connect physically, first of all, it gets interpreted horribly by your spouse. So no matter how much you tell that significant other how much you love them, if you are not connecting with them on a physical level, they do not feel loved.
Right.
And this is a major, major reason why relationships break up. And loneliness, being alone, feeling disconnected, feeling isolated, this is not a recipe for longevity. These are the people that don't survive their disease because what do they have to live for?
And
They're
do you
not.
even think, just real quick, going down this rabbit hole, do you even think that possibly that's why we're seeing almost an increased incidence of cheating? You know, I mean, yes,
100%.
you know, we're making it more socially accepted for some odd reason with Ashley Madison crap out there. But I'm almost wondering, hearing you talk, and this is going off in my brain as we're speaking, that is it that the low libido not being taken care of by either sex? I mean, this goes for men too, because we're seeing a demasculinization of America with men's testosterone levels going in the toilet from all the xenoestrogens and chemicals and the statins we're giving them and everything. But it maybe the reduction of testosterone and not addressing that particular hormone and estrogen in conjunction with libido dropping down. Now, just like you said, the other person feels unloved, unwanted, undesired. They're going somewhere else. I mean, I'm sorry, that's a hard truth, but
it is.
It
is absolutely, absolutely a huge contributing factor, because when you don't have that physical connection and when you're not on the kind of same wavelength, right? When one spouse wants to have a physical relationship and the other one doesn't, that is a drive in us. That's there for a reason, right? That's so that the human race survives. And whether or not you can still procreate, that drive shouldn't change. It's our like raison d'etre, like our reason to be. And it shouldn't go away. And so when it does, and when you're not connecting, that is a huge obstacle that is put inside of a relationship. And relationships are hard enough.
Right. Exactly.
Right? Like they're hard enough. I mean, I'm married 21 years. Like being married is really hard. And that shouldn't be the hard part.
Right.
That shouldn't be the hard part. Like that part should be easy and automatic. That should be the thing that the two of you agree on. And if you don't, and if it's because you lack a libido because you just don't have hormones, that should be corrected.
Yes. Yes, absolutely. I know we just went from breast cancer to sex and libido, but they're all tied together. And that's why I love these conversations. We don't know where they're going to go. We're just going down this road now.
Yeah.
And then
But
we'll come back.
listen, that becomes a major element in the world of breast cancer, because what happens to these women, right? So they get diagnosed with breast cancer, they get treated for breast cancer, they completely lose their libido. They
Mhm.
lose they already, their femininity, their sense of self, their sense of being a woman is so challenged,
Mhm.
right? Like, we're not talking about the pancreas or the colon or something that's not like front and center. We're talking about a physical sexual organ.
Yeah.
And so they lose that, even for the women that have lumpectomy. I mean, it is just still such a damaging part of your femininity.
Mhm.
And then, you know, I see this happen so often where the spouses are supportive to a point,
Mm.
and then they lose that physical connection because that woman just doesn't feel like being physical anymore because of all the things that she's gone through and all the things that are done to her. And you can only sustain that relationship for so long. And so many women end up in divorce
Mhm.
after their breast cancer diagnosis because they lose the last connection between them. And this is so avoidable if we would just take care of these women, because women with breast cancer are women too. And
Yeah.
they deserve to be treated like women, and they deserve these same exact advantages and access to
Mm.
the very same things that drive health that we're offering to everyone else. And, you know, estrogen receptors aside, these women are candidates because estrogen does not cause breast cancer. So, you know, to dovetail back to that, what about women who have estrogen positive breast cancer?
Mhm.
My answer is, and, you know, this sounds very insensitive, but like, so what?
Yeah.
Tell me something I care about, because that's not it,
Yeah.
right? Like that is not putting you on my no list. There are some things that are going to put you on my no list, you know,
Right.
like if you're not willing to do the work, if you're not willing to figure out why you got breast cancer, because there usually is a reason that we can identify.
Mhm.
If we can't correct what got you there, I'm not gonna like stand by and let you be in harm's way. I'm gonna tell you, like, I'm not your person,
Right.
right? Like, I need to be in a partnership, and I need to know that I am continuing to support you in your longevity. And if you're not supporting you in your longevity, I can't really help you. But the fact that you had estrogen positive breast cancer is never going to be the reason why I'm not giving you hormones. Never, never.
Well, why do we categorize like the ER positive, this positive, that why are there even those categories that
Yeah.
only further scare women?
Yeah. It's, well, and what's so interesting is I wish women understood that, like we said, it is normal to have estrogen and progesterone receptors on breast cancer cells.
Right.
And it's actually the ones that don't have estrogen and progesterone receptors on them that you have to worry about a little more. And it's not because they have less treatment options, it's because they are a further departure from normal. These are cells that are really in trouble. They've lost their way, right? They have mutated to the point that they don't really look like breast cells anymore. They're
Mhm.
very immature. They're like the outliers,
Mm.
right? And we don't talk about that enough. And again, I don't want to scare people because that's never my way, but that when I meet someone who does not have a hormone positive cancer, I'm a little more accelerated in my timeline. I'm like, we got to figure you out fast because we got to turn this ship around,
Yep.
right?
Yep.
So the reason that the conventional medical world talks about it, and listen, I'm not pointing fingers. I came from that world. I
Mhm.
lived in that world for a very long time.
Mhm.
I operated, no pun intended, in that world for a very long time,
Right.
right?
Right.
The reason we do that is because our medical training, when we go to medical school, we're taught, here's a constellation of symptoms, give it this name. If it has this name, give it this drug. send them on their way.
Yep.
Next.
Yeah.
Constellation of symptoms, this name, this set of drugs, next. Right? So that's why it's okay. We have hormone positive breast cancer. We're going to give this drug, off you go.
Yep.
Right?
Yep.
5 years, off you go. Now we have some women who are getting in the breast cancer index because they have high risk disease. And now we're saying, we're going to give you those drugs for 10 years and then off you go. Right? So, and if you don't have hormone receptors, then you get put in another silo and here's your list of drugs and then off you go. Right? But it's only for the purposes of matching up, what drug am I going to give you?
That's the same thing in the thyroid world. It's check TSH. If TSH is above the standard lab value range, give T4, pat them on the head, send them on their way and wish them luck. I mean, that's exactly how it is. So it's really no different.
But unfortunately, that paradigm is landing everyone in my office.
Oh, well, exactly. Right.
So that is just how we haven't corrected that paradigm. I will really never know. And did I read that 1 in 4 women now have thyroid dysfunction and are on thyroid hormone replacement? I mean, that's a crazy statistic. And the fact that we are not jumping up and down, screaming and yelling about this is crazy to me. That we're like, okay, all right, I'll take that pill.
Yeah.
Crazy.
I agree. And just like hormones, listen, I don't care if you're on thyroid hormone replacement the rest of your life or bioidentical hormone replacement the rest of life. I hope you do BHRT the rest of your life, but it's proper treatment. It's giving people the right combination of those thyroid hormones or those bioidentical hormones that they need. So whether you're a thyroid patient dealing with conventional medicine and getting one medication, or you're going to these hormone clinics that treat you like cattle, just in and out the door. Here's the same hormones and the same dose over and over and over again. Both sides of the equation are doing an injustice to people.
But also, I mean, just replacing T4 is a huge problem.
Oh, huge.
A huge problem.
Do you see that does increase the risk of cancer when people are on T4 only? And is it tied to just that they're not quite optimized on T4 only, or T4 only is driving up their reverse T3? Do you see any correlation with cancer?
So what I'm seeing is just an increase every single year. I'm seeing more and more women come to my practice on years of T4. Just years of T4 alone. No one's checking antibodies. No one's asking why the dysfunction is there. And again, I'm with you. If you need thyroid hormone replacement, I get it. Right? It is a life changer for many, many people. And there are so many toxicities in our environment that are driving this thyroid dysfunction. I mean, let's put a plug in for people. Please stop using fluoride in your toothpaste.
Seriously.
Please filter your water for for fluoride. Avoid things with bromide in them. This is really contributing to thyroid dysfunction and thyroid disease. And you can have even normal thyroid hormone levels. And if you are replaced with, if your iodine in your thyroid hormone is replaced with fluoride or bromide, it's not going to work. So we have to get these things out of our system. I just saw a post today about talking about fluoride, and it blows my mind that people don't know to avoid fluoride.
I know.
Blows my mind.
It's pushed out to 9 out of 10 dentists recommend Crest. It's pushed to us the same way that drugs are pushed on TV and in the media, and big food is put Pepsi is safe, right? Have a Pepsi. Kids are drinking Pepsi.
Well, the sugar industry said so. So,
Exactly.
you know,
Exactly. So
there's that very reliable source.
yeah, no, it's pushed on us the very same way. And you and I just interviewed David Brownstein. We were talking off air of how just
Yeah.
intrigued we are by this man and his knowledge of iodine. Did you find prior to interviewing him, were you using iodine with your breast cancer patients? And if not, after talking to him, are you like, holy cow, every single patient is going to be on iodine now? What are your thoughts?
So I want to be honest with you. I was using iodine,
Mm-hmm.
but I was not using
Really
nearly
enough.
enough.
Yeah.
I was kind of embarrassed when I had him on because like I was giving people like the recommend, this is his book that
Yep.
is just the Bible.
Yep.
Um, I was giving people what I thought was adequate amounts of iodine based on the recommended daily allowance. And, you know, sometimes I was doing a little more and I was doing the iodine patch test. And I was like embarrassed on how poorly I was doing it until I had him on. But, you know, I think that's the thing about being a good practitioner in this day and age is that you remain curious
Mm-hmm.
and you're willing to learn and you're very accepting of the fact that if you're not embarrassed by something that you did 6 months ago, you're not learning,
Yeah.
right? Like for
Yeah.
me to sit here and pretend that I know everything and that I'm doing everything right, I mean, it's absurd.
Yeah.
Now, am I making the best decisions with the information that I have today? I certainly hope so,
Yes.
right? Like, I certainly hope that I'm coming from a place of honesty and integrity, and I believe that I am. But I am also well aware that I am not an expert in every single thing, and I am constantly learning. I mean, my husband will tell you, like, there is not a time where I'm not reading a book or taking a course, or I am so thirsty for knowledge all the time because I think that not only do I owe it to my patients, owe it to the people that look to me to be an authority, but I innately, I just really want that information.
Mm-hmm.
I
Yep.
I want to know that if I want to know. I
Well,
want
that's
to
why we
know.
interview people. That's why we don't do
Yeah.
just solo episodes, right?
Yeah.
Where it's just us on here talking about our knowledge.
Yeah.
We need to get that knowledge out to our listeners, to our audience, to our patients, so that they can be better informed. And you're right, Jen. I mean, I do the same thing. I'll have someone on, I'll be like, listen, after speaking to this expert, I have now changed my optimal range for XYZ. I've changed my stance on whatever it is
Yeah.
because they know better than I do. And I'm learning from the experts as well.
Yeah.
So,
Yeah.
no, I love that. I love that.
And I think there is something to be said for that continued kind of learning in real time in that, you know, when I trained to be a functional medicine doctor, not for nothing, but it was 5 years ago.
Mhm,
When I trained to be a breast surgeon, I'm like embarrassed to say this, but that was 30 years ago,
mhm.
right? Like things have changed.
Yep.
And that is one of the places that I really object to in conventional medicine because they don't do enough of the what is true now.
Yes.
And there are so many things that were taught to me as like indisputable when I was training that are very, very disputable,
Well, I want to
right?
say it was Brownstein that I heard on another podcast who said that in medical school he had a professor that was just so profound that told him on the day of graduation 3 years from that point 50% of everything you learned in med school will be obsolete.
Yeah.
50%, 3
But the
years.
problem is that there are people talking about that in real time that are being ostracized by the
Yep.
medical profession because they don't like that. They
No,
don't
we don't want
like that.
change. Yeah.
Yeah.
No, no, no.
They
It's
don't want
drugs.
change. They
Drugs
don't want to
fix
be
you. That's it.
corrected. They don't,
Right.
yeah. And the drug thing becomes really important because, you know, you and I talk about bioidentical hormone replacement.
Mhm.
But the drug industry has a big problem with this because you cannot monetize a molecule of nature in
Right.
that, right?
Right.
And so, they can't patent it, and that's a big problem for them.
Well, and
And
why is testosterone literally classified as what? It's a Schedule C. It's in the same
yeah, it's
category
a
as
controlled
opioids.
substance.
Controlled substance.
I need to
Right.
have my DEA. I had
Yep.
given up my DEA when I became a functional medicine doctor because I'm like, when am I going to prescribe morphine and
Right.
Percocet? And I'm just not going to do it. Like, there's no reason for it. And then I went and wrote for testosterone gel for one of my patients. And the pharmacy called me and they said, "Where's your DEA?" I was like, "I don't have
Mhm.
a DEA." They're
Mhm.
like, "You need it for testosterone." Now, having an 18-year-old who works out at a meathead bodybuilder gym, I now understand why testosterone is a controlled substance, because there is an entire generation of men and women.
Yeah.
I'm not calling out the men. There is an entire generation of people that are for sure abusing it.
But
For
girl,
sure.
I was competing 25 years ago and they were abusing it long before I even stepped on the stage.
Yes, for sure.
So it's not, this isn't something new and novel
No,
to your son's
no.
generation, right?
Yeah.
So yes, there's always the people that are going to overdo it. I mean, good Lord, the bodybuilders were using T3 to lose weight too when they didn't have a thyroid problem.
Yeah.
But then what about the people who truly need it? And my whole theory is that we're making it so hard to get testosterone because testosterone will keep the guys and the girls off the statins, and they'll keep you
Well,
off
that's exactly right.
antidepressants, and they'll keep you off right, all of these
Well,
drugs that band-aid the symptoms of low testosterone.
so, that is really what I believe was the problem behind the Women's Health Initiative study, is that I think from the very start, it set out to get rid of hormone replacement in favor of using all the other things. And in fact, one of the study investigators, I can't remember who it was, but one of the study investigators kind of said, like, why do we even need hormone replacement when we have statins to control cholesterol, and we have beta blockers to control palpitations, and we have SSRIs to control depression, and we have anxiolytics to control anxiety, and we have sleep meds for sleep, and we have bisphosphonates for bones, and we have NSAIDs for joint pain. Right? Are you getting the picture
Oh my
here? Like, why
God.
have
This is-
one thing
Yeah.
when you can create an entire industry and have 7 or 8 or 9 or 10 things? Because that's what it comes down to, right? Like, when you think about all the things that hormone replacement does in the body, then there's a lot of things that you need to put in there to support someone, and they don't even work. Well, they work for the pharmaceutical companies because they make a fortune,
Mhm.
but they don't work for the people taking them. I mean, the numbers around statins are dismal. Like, you have to treat, is it 82 or 83 people for one person to benefit from it? That's crazy. And you
All right.
have a 63% increase or something in diabetes if you're on a statin. Like, seems like we're trading in one big problem for another,
Yeah. Yeah.
right?
Huge problem.
And I mean, I just don't even like where we went with the cholesterol narrative anyway, in that cholesterol is the molecule of life. It's
Mhm.
the base to all of our hormones, it's the base to our neurotransmitters. We can't create a cell without cholesterol. Like, what are we doing lowering these people's cholesterol to these crazy low numbers? And they're losing everything. They're losing their brain, they're losing their body, they're losing everything.
I know. I
It's
know. It's
terrible.
crazy. It's
It's
crazy.
terrible.
Oh my God, I could talk to you forever and go down so many rabbit holes. But we need to get on to the testing too, because this is a big
Yeah.
question I get from my patients, from my audience. And honestly, I'm even confused. So years ago, I felt a lump and I thought, well, you know what? The first thing I'm going to do is get a thermography, do thermography, because I heard that's
Mhm.
so much better than a mammogram. So I do the thermography, and all that comes back is, yes, you have red inflammation. We suggest you get a mammogram. I'm like, son of a bitch. Now I wasted 2 weeks waiting for the thermography appointment. Now I got another 2 weeks of worry waiting for my mammogram. So I go in for the mammogram. They have to do the whole 3D because I have breast implants, all that, ultrasound. And it comes back, okay, we have to biopsy you. So they biopsied, it was benign. I was fine. But all of that testing made me think, what in the actual, like, what is a woman supposed to do? We hear mammograms are radiation. Don't do mammograms every year, do thermography. Well, the thermography told me to go get a mammogram. What do we do?
I
And is
know
there a better way?
it's so confusing. And this is another one of our systems, which is completely built on a foundation of fear, right? I mean, what we're doing to everyone. Because if you stop and think about it, of course, mammograms are dangerous. Of
Mhm.
course, radiation causes cancer. Everyone knows that. If you asked 100 radiologists, does radiation cause cancer? They would all say yes. Then you ask those same radiologists, do mammograms cause cancer? They all say no, right? Like, it's crazy.
Yeah.
We've had beaten into our heads, mammograms save lives, mammograms save lives. So what does everyone do every year? Like, they get a mammogram because they're told to get a mammogram, and they believe that mammograms save lives because it's what they've heard a
Yep.
1,000 times, and it's what their doctors are telling them to do.
Yep.
And listen, when the mammographic screening program started in the 1970s, it started with very good intention.
Mhm.
It was a way to screen people for breast cancer, for sure.
Mhm.
But it was entirely based on this premise that breast cancer growth is both linear and predictable. So it assumed that breast cancer started at this small size, grew to some critical mass, at which point it would be more likely to metastasize. And so if you could find this lesion before it reached this critical size, you could both save lives and save breasts. And it's a great, great, great theory. Just
Mhm.
doesn't happen to be true. Breast cancer is what it is from the very beginning.
Mhm.
So if it's going to be an aggressive process, it's going to be an aggressive process. And it doesn't matter where you find that process, right? So early diagnosis of an aggressive cancer is still going to be an aggressive cancer that needs aggressive treatment. And late diagnosis of an unaggressive cancer doesn't matter. The interesting thing is that when we look at the population of women that screen and the population of women that don't screen, there is no difference in death from breast cancer. They are exactly the same. Here's where the difference is. There are many, many, many more breast cancers in the population of women that screen, because we are identifying all these lesions that would have never become clinically relevant. They just would have we would have never found them. These women would have never gotten treated. These women would have never had to suffer under that belief that they had breast cancer and that their life is threatened,
Yeah.
right? And yet it's very good for the system. And so we do 37.5 million screening mammograms in this country every year. Now, what does that lead to? Well, that
Fear.
leads to breast biopsies like what
Yep.
you had,
Yep.
right? And 75% of women who undergo breast biopsies have the same experience you did. They're benign.
Yeah.
They're done for benign disease. So
Yeah.
you had all that worry, you had all that stress,
Yep.
you had all that expense for what? For nothing.
Nothing.
For nothing. You didn't need it.
And then I was told to come
And
back a year later, which I never did. So yeah.
and the more mammograms you have in your life, because it's radiation, because it just builds up in the tissue, we don't get rid of it. It just builds up in the tissue. The more mammograms you have in your life, the higher the risk is of you developing breast cancer. The higher the risk. The earlier that you start, the higher the risk is of getting breast cancer. And that's because younger women have active breast tissue, right? So, and they also have more breast tissue as compared to fat because they have to prepare to feed a child every month, which
Yeah.
is not so true in older women.
Yeah.
So when you take that woman with an active breast, with a dense breast, they actually need more radiation in order to see through that tissue. So these women are getting up to 10 times the amount of radiation that someone with a small, non-dense breast would get. And they are more likely to be affected by it. So they're more likely to get breast cancer as a result because they get more radiation and there's more damage done.
Yeah.
So it's a huge problem.
Yeah.
Overdiagnosis and overtreatment is a huge problem for all the reasons that we talked about before. I mean, just the psychological burden of getting a breast cancer diagnosis is enough.
It's
But
enough.
then you put on the financial burden of having breast cancer, and that's enough. But all of the treatments for breast cancer accelerate heart disease, accelerate bone loss, accelerate dementia, Alzheimer's, mood disturbance. I mean, I could go on and on about all these things that happen as a result of treatment for breast cancer. But the bottom line is this. If you treat someone for breast cancer with our conventional treatments, you are shortening the duration and decreasing the quality of their life. So we really have a problem of overdiagnosis and overtreatment.
Yeah.
So let's get back to your initial question, like, what's a woman to do?
Right.
So I do want to address thermography because it's a very good point that you bring up. Thermography is a wonderful tool, but it's not a screening tool for breast cancer.
I've learned
And
that.
that's the major problem, is that it has been marketed as a screening tool for breast cancer, and it's not.
Right.
It is a screening tool. It looks for a heat signal. It's a screening tool for inflammation. And when you use it as a screening tool for inflammation, it is very valuable. It is very valuable. I have found lots of people who said, I don't have any problems with my mouth. I say, let's see. And we get a whole body thermography and their mouth lights up, right? And this is a major source of like the inflammation that eventually leads to breast cancer that we're not talking about enough.
Yeah.
We're just not talking about it. And so, you know, I have really in the last 2 years really incorporated biologic dentistry into my practice because that is such a major source of inflammation for people. And, you know, the papers have been around about the periodontal disease and its connection to heart disease.
Right.
Those papers have been out for a while, and I think that people generally accept that. But when are people talking about that in breast cancer? They're not, but we need to be.
Right.
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 So, and, you know, it can often identify areas of inflammation all throughout the body. And so I really do use that as a screening tool for inflammation. But it's not a screening tool for breast cancer.
Right.
Because you have to have a considerable inflammatory response in your breast cancer. And most of these breast cancers are very slow growing. Now, do we need to discover all the breast cancers? No, we don't. Because that's where all the overdiagnosis comes from.
Yeah.
Some people talk about ultrasound as a screening tool for cancer. I'm okay with it. The problem with ultrasound is the images are very, very low resolution. So if you find something, you almost have to biopsy it because you can't tell what it is from the ultrasound images. So that is going to lead to a lot of unnecessary biopsies. The other thing is that we haven't exactly perfected the automation of it. And so in order for it to be a screening tool, we really have to have something that can be relied upon and repeated over and over and over again, and we know works. So it's not a bad tool. It's not a perfect tool at all. And then for a while, we believed that MRI was going to be the solution, but there are so many problems with MRI. MRI is kind of overly sensitive and lacks specificity. So it finds a lot of things that are not meaningful and leads to a lot of unnecessary biopsies and a lot of overtreatment. And there are many, many, many women who undergo mastectomy based on findings of an MRI, only to find out that they don't have any disease in their breast.
Yeah.
So this is a huge problem. But the worst problem with MRI, well, that's a pretty bad one.
Yeah.
Let's say another problem with MRI is that it requires gadolinium. And gadolinium is a heavy metal.
Mm-hmm. Yep.
Heavy metals, when we introduce them into our body, they are stored, and they are stored at the expense of something else, something that you need, something that is necessary. And the areas where they're stored, that will cause pathology. So it's causing brain pathology, it's causing kidney pathology, it's causing bone pathology. This is very real. So beside the fact that they are expensive and that there are access issues, MRI is just not a solution for us.
Okay.
And I never really like to talk about a problem unless I have a solution. And I'm just so delighted to be talking about perfection imaging, because what we're talking about now is a screening tool that has 40 times the resolution of MRI. So we can actually see down to a cellular level, but we're not compressing the breast. There's no radiation. This is sound waves transmitted through a water bath that actually collects 200,000 times more data points than MRI. And what ends up happening is that we can then create a three-dimensional true reconstruction of the breast because we have all of these data points. It's not like an average of some data points. This is a true 3D reconstruction of the breast.
Okay.
And the most important part of this technology is that it's functional. And what I mean by that is that we can image a woman, and if we see a lesion, we can bring her back in 60 days, re-image her, count the cells, and measure a doubling time.
Okay.
If that doubling time is less than 100 days, we know that this is an active process, that this is probably a cancer that needs to be dealt with. But if that doubling time is greater than 100 days, we know that this is not something that we need to worry about. And so what this technology avoids is over biopsy, because we're getting rid of all those people with the benign lesions that don't need a biopsy.
Right.
We just don't need it. It's getting rid of overdiagnosis, and it's getting rid of overtreatment. And at the same time, because it is 100% safe, we're not creating more breast cancer patients. We're not causing breast cancers. And this is a disease in this day and age, in this toxic environment, this toxic soup that we are all swimming in. Like, we don't need more things that cause cancer.
No, we don't.
And this technology will avoid that. And I'm so delighted. My first center is opening just outside of Philadelphia in July, and I have many behind it. And so, I've made it my goal to make sure that everyone who wants access to this technology gets access to this technology. And in very short order, this is going to replace mammogram, ultrasound, and MRI. And, the mammogram industry, the MRI industry, they're going to go kicking and screaming. They do not want this.
No.
And I get it. Right?
You're ready for the battle, right?
Yeah.
You're ready for the battle.
I get it that they don't want this,
Yeah.
I mean, they've built a huge business on this. Huge. Like $1 trillion business they've built on this. But it's time for change, and we deserve better. As women, we deserve better. And we are living after centuries of men controlling this space. I mean, can you just imagine if you told a man that he had to put his prostate between two plates have it squeezed down to a fraction of its size and radiated to take a picture of it every year. How would that go?
Right.
Right? Like
Exactly.
it would never freaking happen.
Right.
But we tell women that, and all of a sudden it's acceptable and we have to do it.
Right.
Right?
Exactly.
Like
Oh my
the times of men running this world in this way are over. We need to use our voices. We need to demand better. And we need to say, no, I'm not doing that. That causes cancer. That's bad for me. It's not saving my life. And we need to demand better.
Yeah, we do. Well, you're giving better. So your first center, and when this opens, we're just going to blast it on our social to let everyone know that it's open. So
Yeah,
when your first center
amazing.
opens outside of Philly, how do people do they just call, make an appointment? Because I'm planning
They
on I'm
they
going to
they
fly
can
down to
actually,
Erie, visit my parents, and drive over.
yeah, they can make an appointment now. You just need to go to perfectionimaging.com, and my perfection is spelled with a Q. PERFEQTION
Oh, I
imaging.com.
like that. Okay.
Mhm.
Yes, we'll
Yeah,
put that in the show notes as well. We'll put that link in the show notes. But
thank
this is
you.
just amazing. I'm just so happy that you are bringing this to the world. I remember you talking about it, gosh, about 6 months ago. So I'm super pumped that it's come to fruition because this is going to be
Yeah,
an answer to all answers for so many women. So
yeah.
many women. And I can't let you go. I know that, like I said, we could talk for hours, hours. I can't let you go without bringing up your book, The Smart Women's Guide to Breast Cancer. Tell us a little bit about the book and what made
Yeah.
you write it. Obviously, your 30 years of experience, for goodness sake. But yeah, what can women expect from that book
Yeah.
and who's it for?
So I basically it took up the last 18 months of my life,
Mhm.
right? But it was really important for me to do. And it was important for me because I knew that I wanted to help millions of women. I knew I wanted to change the way that we diagnose, reverse, prevent, and screen for breast cancer. And I knew that my work one-on-one with women, which is so rewarding. So don't get me wrong, but I can't help millions of women one-on-one.
No,
But
right,
but so much of what I do with these women, like 80% of it is how I help them change their lives. 80% of it is how I help to educate them. So many women get a diagnosis of breast cancer and they are just thrown on that train, on that treatment train, right?
mhm,
Like, got to see, you got to get your biopsy. Okay, you got your biopsy, you got your diagnosis, you got to go see a breast surgeon, you got to get scheduled for surgery, you got to go see the medical oncologist, you got to go see the radiation oncologist. Everyone is like, rush, rush, rush. I'm going to schedule you for surgery. I'm going to schedule you for chemo. I'm going to schedule you for radiation.
yep,
No one has time to think. They are so scared. And how are you supposed to make an educated decision when you are in that position? You can't. It's impossible. And
right,
then you have everyone around you giving you the you shoulds, right? You should do this and you should do that. And you should go see this person. You should go see that person. And people get so disillusioned, like medicine is provided by four walls,
yeah,
right? And if you
yeah,
go to some fancy cancer center, like they're doing it better. They're not doing it better. They're doing the same thing.
same thing,
And I wanted people to be able to truly make an educated decision, to truly know how much that chemotherapy was really contributing to outcomes, and at the same time, knowing what else that chemo does, because people don't know and people don't understand. And they're also not getting information about how to make those treatments better, what
right,
supplements to take, how to fast while you're getting treated. So I thought that there was so much information that it was just so important to put out there so that people could actually make an educated decision, and I
mhm,
could get them 80% of the way there. I could teach them how to eat. I could teach them how to move. I
yep,
could teach them how to manage stress, how to get rid of a considerable amount of toxins, how to detoxify, and the importance of knowing living a connected life and kind of learning about your purpose and living in a purpose-driven way,
Yep.
because all of that really matters. And so I thought, well, I have all this information in my head. I have all this information that I'm sharing with my patients. Shouldn't I share it with the world?
Yeah.
And so
Yes, you
that's why I
should.
wrote my book. That's why I wrote my book. That's why I wrote The Smart Woman's Guide to Breast Cancer. That's why I'll write another one, because we are learning all the time. And I feel a sincere obligation to put out information in the world with generosity and abundance, so that, listen, if the information out there in the world were everyone's solution, then we would all be well and healthy. So,
Yep.
there's always, always, always more. And I'm just trying to give people information that they need, that they can use right now
Right now.
to make a difference. And I on purpose did not make a 400 page or 1,000 page book. Like, I wanted it to be something that is super useful but easily digestible and practical. And I think I did that. I mean, the response has been
Amazing.
amazing.
Yeah.
And so, I'm really proud of it. Is it perfect? No. Do I like wake up in the middle of the night and say, oh my God, I should have done this, and oh my God, I should have done that?
Well, that's
For
why there's
sure,
revisions to the book. You're fine. Yeah.
100%,
Yeah.
right? But but it's pretty good. And and I know that it's going to help millions and millions of women. And
You're
for
just too
that,
humble.
I'm very proud.
You should be proud, and you're too humble. It's not very good. It's amazing. And
Thank you.
you poured your heart and soul into it. And so really this book is for every woman. And
Yeah.
that's the message. It's for every
Yeah.
single woman. So if you're a woman, you need to click the link below, order the book. You will not regret it, because the harsh reality is we're going to know someone, a woman in our life that gets breast cancer,
Yeah.
whether it's us or someone close to us.
Yeah.
If the stat is 1 in 4, then, do you know 4 other women? I do, and
Yeah.
then one of us
Yeah.
is going to need this book. So, whether you get it for yourself, your daughter, your mother, or a friend, every
Yeah.
single woman should get this book.
Yeah. And it's also, it really covers prevention.
And that's what we
And
need, right? That's
yeah.
what we should be
Yeah.
doing.
And as much as I would love it for people to come to me and say, Dr. Jenn, like, tell me what I need to do so that I don't get breast cancer. That is like a pipe dream of mine, because it
Yeah.
doesn't happen, because most people do not act until they're in crisis. And I get it, right? Like, I was a patient too. That's how I got into this space. So we don't change until the proposition of staying the same is more painful than the prospect of change,
Yeah.
right? Like, that is when we change, when staying the same is more painful than changing.
Yep.
And so I really had every woman in mind when I wrote this book. I had the people that have not had breast cancer yet and want to avoid it, to the people who are just diagnosed, to the people that are going through treatment, to the people that have completed treatment and are wondering now what I call the silence after the storm, and to the women that are living with metastatic disease, because that's 25% of my practice.
Yeah.
And I'm so delighted to say that, like, they're thriving too.
Yeah.
And healing is possible at every age and at every stage, but you just have to come at it a different way, because the definition of insanity is to do the same thing over and over again and expect a different outcome. And if we
Exactly.
want a different outcome, we have to do it differently. And that's why I'm so grateful for people like you who are out there talking about how to do it differently, because that old way, it doesn't work. It
No,
doesn't work. And
it
we need
doesn't.
to do it differently.
Well, I'm grateful for you as well. And everything that you shared on this podcast, your book, your new testing facility, your new testing method, your knowledge. Oh my gosh, this has just been amazing. Just amazing. I'm just blown away every time we talk. So
Thank
thank you so
you.
much, Dr. Jenn,
My
for coming
pleasure.
on and
My
sharing
pleasure.
everything. And
It's
we'll put
been
all the links in
wonderful.
the show notes. We'll put the links for the Perfection Imaging. We'll put the links for your book. We'll put the links for your website and how people can find you. So this has
Awesome.
been absolutely amazing. Thank you.
Awesome. And if you want to hear more from me, I also have a podcast that Dr.
Yeah.
Amy will be on, and it's called Keeping Abreast with Dr. Jenn. So stay tuned for Dr. Amy's episode.
And that's on all podcast platforms too. We'll put that link
Yes.
in as well.
Yes.
All right. Thanks, Jenn.